Dear committee, dear audience, let me introduce my PhD thesis, which is continuous glucose monitoring and diabetes. My name is Gabriella Rákóczi. I'm a dietitian, a CGM specialist, and a first-year PhD student. My vision is to decrease the incidence of diabetes mellitus, and my mission is to identify and correct dysglycemia before it develops into diabetes. To achieve my mission, I have two specific goals. The first one is to investigate the diagnostic accuracy of CGM on dysglycemia, and the second one is to investigate the effect of non-pharmacological intervention on the reversal of type 2 diabetes. Let me introduce my first topic, investigating the diagnostic accuracy of CGM on dysglycemia. Why is it important, and what is CGM? Diabetes is a public health burden with immense healthcare and societal cost. Almost 500 million people are affected worldwide with elevated risk of premature death. A significant number of these cases are preventable with proper lifestyle changes. Most of these cases are diagnosed at a late stage, which can lead to various complications, such as cardiovascular disease, vision loss, nerve damage, and kidney failure. The early detection of glycemic disorders could improve with the detailed insights from CGM. What is CGM? CGM, continuous glucose monitor, is a tool that can measure blood glucose levels throughout the day. It usually consists of a sensor worn on the upper arm and either a handheld monitor or a smartphone app. What is the problem with the conventional glucose measuring methods, and what are they? These include hemoglobin A1C, fasting glucose, and also OGTT. These are providing a snapshot or an average of the blood sugar levels. However, CGM can give us much more information about nocturnal hypoglycemia and also postprandial hypoglycemia. My aim in this study is to investigate the diagnostic accuracy of CGM. So my clinical question is, do CGM metrics help identify the early signs of glycemic disorders? The population observed is healthy, normal population. We are comparing the CGM data to the conventional glucose measuring data, and the outcome is the detection of dysglycemia. My hypothesis is CGM use can help identify the early signs of glycemic disorders. And the clinical implication would be, if we can identify the early signs of glycemic disorders, then we can introduce necessary measures to prevent the development of diabetes. After made our systematic search with this search key, we have two domains. The first one is for the continuous glucose monitor. The second one is for the conventional glucose measuring methods. We found over 17,000 articles in 3 databases. Here you can see our key articles. The population in each case are non-diabetic healthy population, and they are comparing the CGM data to the conventional glucose measuring data. And the outcome in each case is the dysglycemia identified. Here you can see our progress so far. After the duplicate removal, we have found 12,000 articles, and we just finished the title and abstract selection with 17 hits. About my second topic, which is investigating the effect of non-pharmacological intervention on the reversal of type 2 diabetes. Type 2 diabetes has reached epidemic proportions globally, even if it's not an infectious disease. It is driven by factors like poor diet, physical inactivity, and also obesity. The chronic nature of type 2 diabetes mellitus also affects quality of life. Lifestyle factors play a critical role in controlling blood sugar levels and also reducing insulin resistance. Dietary and lifestyle changes could lead to type 2 diabetes remission. Our aim in this study is to investigate the effect of non-pharmacological interventions on reversing diabetes. And the clinical question is, do lifestyle factors help reverse type 2 diabetes? The population observed is a type 2 diabetic population. The interventions are different types of diet and physical activities. and the outcome is the remission of diabetes. We have primary and secondary outcomes as well. The primaries are the hemoglobin A1C, fasting glucose, and OGTT, and the secondary outcomes are lipid profile, BMI, blood pressure, and also inflammatory markers. Our hypothesis is that lifestyle changes can help reverse type 2 diabetes. And the clinical implication would be reduction in complications, improved quality of life, decreased medication dependence, and also lowering direct healthcare costs. First of all, to be able to conduct this study, we need to know what diabetes remission means, what is the criteria of this. Concerning to the ADA from 2021, it means that the hemoglobin A1C level must be below 6.5%, and it must be measured at least 3 months after cessation of any kind of glucose-lowering drugs. After the preliminary search, with this search key, we have 3 domains. The first one is for the diabetes remission, the second one is for the intervention, and the third one is for the type of studies that we are including, randomized clinical trials, over 500 articles found in 3 databases. Here you can see our key articles. The population is type 2 diabetic population in each case. Interventions are different types of diet and exercise habits, and the outcome is achieved diabetes remission in each case. So to summarize, I have 2 ongoing projects. The first one is to investigating the diagnostic accuracy of CGM on dysglycemia, and the second one is to investigate the effect of non-pharmacological interventions on the reversal of type 2 diabetes. And I'm thanking your attention with my favorite quote, which is, "An investment in knowledge always pays the best interest." Thanks for your attention.
Thank you for your presentation. I think your second project is going to be really interesting. So will you use any kind of exclusion criteria for that search?
Yeah, thank you for the question. We have excluded in the second project, first of all those people who has type 1 diabetes, of course. We excluded pregnant women also. We are excluded those patients who have uncontrolled diseases like cardiovascular disease, liver disease, kidney disease, also acute and chronic pancreatitis. We were excluded those patients. Also, those patients who have overwent bariatric surgery and morbidly obese patients as well, so BMI over 45. And those patients were excluded also who has the hemoglobin A1C over 10%, or who has who cannot be able to reach fasting glucose level, normal fasting glucose levels without insulin. That was the exclusion criteria. Thanks for your question.
So in OGTT, there are different ways how they do it in the clinical practice. If there is 3 points of level of blood sugar management, or 5, if they are checking the insulin levels or not. So are you going to make subgroup analysis on this in the first project?
Yeah, sure. Thank you. We will, if we find enough data to make subgroups for that, but it's a great suggestion. Thank you so much.
I have a question. Hi. Really good presentation. I really like your topic and I look forward to reading your paper. I'm just wondering, if there was to ever be a study that would look at the efficacy of the different types of CGMs, do you think any so far that have been invented are considered the best? Maybe like a Dexcom, I saw there's Guardian. They're coming out like iPhones these days. Is there any that you like?
Yeah, you are familiar with this topic, I heard, because you know what is Dexcom. At the moment, there are many CGM tools on the market, and it's increasing. But there are only 3 types that are ADA approved and also European authorities approved. The one is the Dexcom, the G series that you mentioned. The second is the Medtronic devices. These are usually used in type 1 diabetes. And the third one is, which is, in my opinion, the best one, is the Abbott device, the Freestyle series, which has invented last year the Freestyle Libre 3. It has the MARD value 7.8%, and it's the best, if you are asking my opinion.
I'm going to look that one up. Thank you.
Okay.
Congratulations on your presentation. I have one question concerning on the price and the availability of this device, because if my informations are well, this is not supported by the Hungarian General Health Insurance.
Yeah, you're right. I hope in the future it will be supported by Social Security. At the moment, these are expensive tools. For example, a device like that, only the sensor for the Abbott Freestyle Libre, its cost can be 80 to 100 euros. And it is only one sensor. Okay, it lasts for 2 weeks, but it is still expensive. I hope for the future the best.
Thank you for the...
Thank you.
Just a short comment. Congratulations. So in pancreatic diabetes, so when we remove the whole pancreas, it is supported by the government.
That's good. Thank you. Thanks.
I have only one thing to say, that the CGM is supported for type 1 diabetes in Hungary.
Yes.
Okay, so it's not for type 2, but it's for type 1.
Yeah, 70%, I think, not the whole.
It depends on children and adults,
Yes.
so it's a big difference between that, but it is supported.
Anyway.
Okay.